So as many of you know, I have been listening to season 23 of the Something Was Wrong podcast. And this season is about the Origins Birth and Wellness Center out of Dallas, Texas. Episode 3, she interviews a midwife from a birth center north of Dallas. And while listening to that interview, some things came to mind. And here they are. Now this midwife, she's a certified nurse midwife who owns and runs this birth center north of Dallas. And she kept saying over and over again, people need to know that there are options for them and there are safe options, and that people can choose to do birth center births. As someone who serves primarily underserved individuals and my patients are on Medicaid, the first thing that came to mind was, well, does her birth center take Medicaid? And as suspected, the answer is no. Her birth center does not take Medicaid. In 2023, 41% of the births in the United States were on Medicaid. 49% of the births in Texas were on Medicaid. And here is a racial and ethnic breakdown on Medicaid births between 2021 and 2023. Pause to read. So a birth center birth is not an option for everyone. If the birth center doesn't take Medicaid, it's not an option for them. Now, birth center services must be covered under Medicaid per a federal mandate, but reimbursement and other policy barriers prevent birth centers from serving more Medicaid patients. So it's very common to find a birth center that's not going to take Medicaid patients for whatever reason. And that has to be recognized because given what the maternal morbidity and mortality rate is in this country and the fact that it predominantly affects Black Americans, birth center births are doing nothing, in my expert opinion for what it's worth, to help combat the racial and ethnic disparities in obstetrical outcomes. They cannot do that if they don't take Medicaid. I'm talking about this because it's really hard for me to listen to someone talking about how wonderful a birth center birth is and the things that are different than a hospital birth and what they can do that we don't do, but they don't serve everyone. That does not contribute to health, equity, or equality. Now, there are a few more things from episode 3 that I wanted to touch on regarding birth centers, so tune in for part 2. Number 1, not all birth centers have hospital privileges, meaning that if you have a complication at a birth center and you need to be transferred to a hospital, the providers may or may not have privileges at that hospital. It's more likely that if they are a certified nurse midwife, they do, but even then they may not. That's important for continuity of care. Next, you need to ask, how close are you to the nearest hospital that could take care of me and my neonate if there are complications? And in the United States, it's different for every state what their laws or policies are regarding how close the nearest hospital should be to a birth center in the event of an emergency. In the state of Texas, that birth center has to be within 30 minutes of a hospital. That's the law. But if there's a true obstetrical emergency, 30 minutes is too long. Next, ask them if they keep record of their stats as far as how many patients are transferred out, or what are the reasons for transfer. How many maternal deaths have they had? How many neonatal deaths have they had? Because one thing that people don't understand is if a patient gets transferred from a birth center to a hospital and that patient dies there or the neonate dies there, that stat goes on the hospital's stats, not the birth center or the midwife's stats. Every birth center should be able to tell you with confidence what their transfer rate is to the hospital for non-emergent and emergent indications. And given that, from everything that I've read, the number one reason for emergent transfers from a birth center to a hospital is for postpartum hemorrhage, you need to know what they have to be able to manage a postpartum hemorrhage. What medications? Are they able to send labs? Can they hook you up to more intensive monitoring? Pretty sure they're not going to have a blood bank. That's important as well. In the podcast, she talks about how fetal heart rate decelerations are another common indication for emergent transfer to the hospital. Well, how are they monitoring the fetal heart rate? Is it through intermittent fetal monitoring or auscultation? Is it through continuous monitoring? The last thing this midwife talks about is child labor after cesarean in a birth center. And she says it's a controversial topic. It's not controversial. Child labor after cesarean outside of a hospital setting is contraindicated. Anyone undergoing a trial labor after cesarean in the hopes of getting a vaginal birth after cesarean or VBAC should be in a hospital setting where there's continuous fetal monitoring, 24-hour, 7-day-a-week anesthesia, and obstetrical care providers who know how to manage uterine rupture, period. And a NICU that can manage the neonates delivered because of uterine rupture.